morning. I'm Louise McCullough. It's so nice to be speaking with you guys about the results of the very exciting STEM trial. Can you give us a little bit of a synopsis, Adam?
The SQUID trial for the embolization of the middle meningeal artery to treat chronic subdurals is a randomized controlled trial that enrolled 310 patients and looked at the failure rate over the course of about 6 months.
David, can you tell us a little bit about what that means as far as failure rate, as that's an important component of your trial?
Yes, so people who initially presented to the emergency department were stratified into either a surgical arm or a non-surgical arm. And once the clinical team had made the decision how that patient was going to be managed, they were then randomized to either receive embolization or not as an adjunct to the predetermined treatment pathway. We then looked at failure of those patients as our primary effectiveness endpoint, so the avoidance of failure, basically. And you could fail in one of three ways. At your 6-month CT scan, you could have a residual subdural collection that was more than a centimeter. That counted as a failure. You could have to go for operation if you were initially non-surgically managed, or reoperation if you were in the surgical arm within 180 days, and that counted as a failure. And then stroke, death, or MI counted as a failure if that occurred within 180 days and the death was neurologically related. So if you met any of those three endpoints, you were counted as a failure and did not achieve the primary effectiveness endpoint of avoiding failure. Then we had typical safety metrics as well, neurological stroke or death within 30 days.
Great. So this is a growing problem with our aging population. Adam, can you tell us a little bit about the type of patients that were selected for this trial?
Yeah, you're right. So the VA cooperative study estimates that this is going to be the most common cranial neurosurgical diagnosis by the end of this decade. And as we see the graying of our country and our world, there are a lot of patients also on antithrombotic and antiplatelet medications, which of course makes any hemorrhagic disease more difficult. But unlike many trials, there was no upper age limit. So we were treating patients
Great.
within the trial well up into the upper 90s, and our average age was in the 70s.
Fantastic. And how did you exclude patients? Obviously, you didn't exclude them by age, but how about their premorbid function?
Yeah, as the first cohort that's really being studied for this therapy, we did exclude patients that had a high modified Rankin. So this was mostly patients with significant potential for recovery. Now, we included patients who were disabled if they were disabled within the recent past and there was a reasonable assurance that they were disabled because of the subdural. We do think that this is likely a treatable and reversible cause of dementia and loss of function in older people. And so that's an important aspect of the trial.
And a lot of these patients, we do see neurocognitive decline without frank hemiparesis and some pre-existing and progressive cognitive decline. Are you actually measuring neuropsychological data in your trial?
Yes, we are. In fact, we did do neurocognitive testing within the context of the trial, and that is one of the secondary endpoints we look forward to presenting in the future.
Excellent. Thank you. So tell us a little bit about what this trial showed, Adam.
Well, it showed that the adjunct of embolization through the middle meningeal artery, both for patients who need surgical drainage and for those who are hoping to try and avoid surgical drainage, is an incredibly effective therapy. So the powered endpoint was the entire group, and that was statistically significant with an odds ratio of 3.6. And if you look individually at the groups that required surgery and whether the adjunctive use of SQUID was helpful, there's a strong trend toward that being helpful. And then, of course, if you're going to try and take a patient who's symptomatic and has a 1 centimeter or larger subdural and try and avoid surgery, in that group, the failure rate was up to 60%, which you might understand. That drops down all the way to 20% with embolization.
With treatment. So 60% meaning watchful waiting?
Yeah, so if well, absolutely. Non-surgical management in this patient population, you fail 60% of the time. If, in addition to that management, you add an embolization, that drops the failure rate all the way down to 20%, which interestingly, by point estimate, is lower than the failure rate we see with surgery alone. So that suggests that this therapy is really probably very powerful.
That's impressive numbers, an impressive odds ratio. And obviously, if you can do less is more in these patients, do we know any other factors like length of stay or hospital complications yet, or is that still to come?
Yeah, all those data are still to come and will be collected as secondary endpoints and analyzed.
Fantastic. Really looking forward to the final results of all of it. But these initial results are really exciting because it really means that we can avoid craniotomies in our patients, and especially in patients at that upper age range. I think it's going to be a dramatic shift in the way we care for these patients.
Or also dramatically lower failure even for patients that do require craniotomy. So I think in both cases, these are exciting data.
Yeah, it's a win-win for sure.